Welcome to another webinar from the AMA Steps Forward Innovation Academy presented by the BHI Collaborative. The BHI Collaborative is a collective product of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care. We are committed to ensuring a professionally satisfying, sustainable physician practice experience and act as a trusted partner to help physicians and their care teams overcome the obstacles that stand in the way of meeting their patients' mental and behavioral health needs. Today's webinar is titled, Addressing the Behavioral Healthcare Needs of Our Veterans. Before we get started, please note this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. If you have questions or concerns, please send your inquiries to practice.sustainability@ama-assn.org. In this webinar, a VA expert will discuss key considerations when working with our nation's veterans to address their behavioral and mental health concerns. Today, Dr. Oslin will share prevalent conditions affecting our veterans, as well as helpful interventions and tips on how to engage patients resistant to seeking treatment. And without further ado, let me introduce Dr. David Oslin. Dr. Oslin is the Executive Director at Cohen Military Family Clinic at Penn and Chief Behavioral Director at the Corporal Michael J. Credenza VA Medical Center in Philadelphia, Pennsylvania. He is also a professor of psychiatry for the Perelman School of Medicine at the University of Pennsylvania. And with that, I will turn the conversation over to Dr. Oslin to run through our learning objectives and today's topic. Dr. Oslin?
Great, thank you. And welcome. It's with great pleasure that I am able to talk a little bit about care for our nation's veterans, often thought of as some of the heroes in our country. So what I was hoping to do today is just give you a primer of the VA and what we do and how to interface with us and how we might be a resource if you're in the community. So we'll go through a little bit about the veteran population, their unique needs. We'll talk a little bit about the VA and the structure of the VA. We'll talk about culturally competent ways to talk to veterans and then talk a little bit about how we're organized in our healthcare system so you could better utilize us. So this is me. So the first thing to realize is when people talk about the VA, it's not one organization. We're really 4 different organizations. Most likely you're interfacing with the Veterans Health Administration, which is the hospital system and the outpatient system. We'll dive down into that. But there's also Veterans Benefit Administration, and that's where veterans get their service connection, their education loans, their disability payments, and so forth. And that's a very important piece for many veterans. Not very often are the VBA offices near a hospital system. They're often in a different location. So if you're trying to connect somebody to the benefits office, you'll need to pay attention to where you're sending them. There's a cemetery and IT organization, and then the healthcare system. In terms of where we are in the veterans population right now, there's about 18 million citizens in the US that are veterans. Only about 1% of our country serves in the military now, so that's been a real shift in how much experience individual providers or clinicians have in terms of their own family experiences. Most often they won't have had experience. Of the 18 million, about 2 million are women. And we still have some World War II veterans alive, not very many, but still about 120,000. And the veteran population that's older is about almost half, and that's predominantly the Vietnam vets at this point. And then here's a breakdown of veterans by race. And you can see for yourself. Next slide. So are veterans different than folks in the community? And yes, and we're gonna have some slides that actually compare healthcare needs of veterans versus non-veterans. But I also thought one thing that's very different in the community is something called service connection. And I'm not trying to get you to be an expert in service connection, but think of it as a disability program. If a veteran during active duty is harmed on the job, they're given a disability payment. It's a disability payment for life. And it's to offset the economic losses that that veteran would have for the rest of their life. So if they were a gunner and they lost their hearing, there's certain jobs that they may not have as much opportunity to participate in the workforce with no hearing as somebody that didn't have that disability from their service. And so they would be given a disability rating. It's a percentage from 0 to 100%. You can see on the right the distribution of veterans that have a service-connected disability. So half don't, about 23 have less than a 50% rating, and about 18% have a higher rating, and only about 70% are 100%, what we call 100% service connected. Um, if you're service connected, you get VA health benefits for life as well, no copays, and all your prescription coverage is covered. So not only do they get a disability payment, but they also get all of their health care. So this is a, an opportunity to understand your veterans in terms of whether they have a service connection or whether you might recommend that they seek service connection. If they come to you and have PTSD, for instance, and it's very clear that PTSD is related to their time in the service, that veteran deserves a disability rating and payments for that disability. And we really strongly encourage them to seek out that payment. That's just a primer about service connection. It's a very complicated system, but um, it's worth knowing that it exists. Next slide. So in the health arena, we have 4 missions, and each are really pretty equal for us. So the 4 missions are healthcare. Obviously, we're both a hospital system and an outpatient system. We'll talk about that a little bit. That's probably what people know us for. But we also have a very strong educational system. That we had in last academic year about 120,000 residents of all different disciplines or medical students rotating through a VA at one time. About 30 or 40% of all physicians will have rotated through a VA. The VA pays for that education. The VA pays their academic partners for the time that residents rotate through the VA. So education is a very, very prominent part of what we do in the VA. The VA also has its own research mission, about $900 million goes into internal research. So this is an internal research program. If you're not in the VA, you can't apply for research dollars. And it's to really promote research activities around veteran centric issues. For us in mental health, that would be PTSD, depression, addiction, traumatic brain injury, brain health. One of the flagships for the VA is the Million Veteran Program. So this is now the world's largest DNA bank. It surpasses the European Bank, and is probably the most diverse because it has a strong representation of minorities. And then the 4th mission that people don't realize, and I guess Katrina was one of the times that we played a prominent role, is disaster response. We're often either asked to provide clinicians or staff in different disasters, or even take on the healthcare and settings when there's a disaster. Doesn't come up that often, but it is one of our missions. Next slide. So this is the healthcare system. It's 173 hospitals basically, or VA medical centers, and then about 1,200 outpatient, standalone outpatient clinics separate from those medical centers. So each of those medical centers would have primary care and mental health, and then we have 1,200 other standalone. We call them CBOCs, community-based outpatient clinics. Um, and then there's also 300 vet centers. Those are specific for mental health needs. These are set up after Vietnam to be a place that veterans could go to get care for combat PTSD, where they didn't have to go to the medical center. And there was a lot of sort of disbelief in the medical centers back then, and the vet centers have served a need for combat veterans for a number of years. We do not see health records and the veterans that go to the vet center. So it's sort of a standalone program, very private for those veterans. In terms of who we saw about 9 million veterans in 22. And so in 23, it was about 7 million. And so we're probably the US's largest integrated health system in terms of number of people served. Next slide. So this is what I was alluding to earlier in terms of how do veterans differ from the US population. So this was AHRQ survey that looked at different rates of health disparities and they did it in all ages. I'm showing here women on the left and men on the right for those age 45 to 64 as an example. You can go to this report if you want to see other ages. And you can see the veteran population, is higher in a number of issues: hypertension, cholesterol, heart disease, so cardiovascular risk, arthritis, which really is musculoskeletal disorders, very prominent among veterans. If you think about what they do in service in terms of taking the heavy equipment and carrying a lot of heavy equipment, they do end up with a lot of musculoskeletal diseases. Next slide. And then this is from a mental health perspective, the difference in what we see amongst veterans in our VA population. I would say the other thing about the folks that use the VA, the health system, is it is somewhat of a safety net organization, in the sense that if you have very good insurance and are have a good job in the community, you have the choice to use the VA, but you also have the choice to use your private insurance, and many of those veterans will use their private insurance. So we would see people that are more disadvantaged, maybe underemployed, lower rates of insurance, etc. So from a mental health perspective, clearly PTSD has a high prevalence amongst the veterans we serve. Substance use, both drug use as well as alcohol use disorder, also higher than in the community population. We don't see as much bipolar as in the community, but we do see a fair amount of folks with psychotic illness, which is a little bit surprising in the sense that when people sign up or volunteer to serve in the military, they're usually in the 18 to 25 range and past the major developmental stage for developing schizophrenia. But we do see a fair number of patients with psychotic disorders. Next slide. So how do we think about our healthcare system, and how do we think about health? And that's evolved a lot over the years, and I just want to give you some clues into sort of how we think about the population that we serve. Next slide. So this is the organization of care. So the veterans at the center, our bread and butter is providing primary care to veterans, as well as mental health care. So at the center for every veteran, we try to take on their primary care. And our primary care teams are very much the medical home model, or we call it PAC teams, patient-aligned care teams. Those primary care settings have mental health providers embedded in them. That's our version of integrated care. We call it PCMHI, but it really is integrated care, sort of on steroids, because we really, it's a robust part of the care that we deliver from a mental health perspective. And then outside of this domain is our specialty care programs, and those are wide ranging and vary a little bit by medical center, but would be all the medical and surgical subspecialties as well as the mental health subspecialties, which we'll show in a minute. And we also think of ourselves as embedded in the community, and the community playing a very strong role in patients' health. And we have robust homelessness programs, we have robust vocational rehab programs, et cetera, to help people really shine in their community involvement. Next slide. So this is sort of a crazy diagram in terms of how we think about mental health care. If you think about a pyramid of being the population of veterans that we serve, and with the top of the pyramid being the more severe patients, the bottom of the pyramid being people that don't have identified mental health needs. The way we think about this is on the right-hand side of this slide. So in those patients that are seen in primary care, we do a number of systematic screenings to help identify homelessness, food insecurity, alcohol use, tobacco use, depression, PTSD, et cetera. So people get screened fairly regular, suicidal ideation, pretty much yearly, for screenings for people that are not engaged in treatment. And as I said, at the next level is our integrated care program. So we have a robust integrated care program where we embed mental health providers right into the PAC teams, right into the primary care teams. And they do both brief treatments and time-limited care for folks with more straightforward care needs. That's to increase the quality of care in those programs, and there's a lot of evidence base for that. And then as you go up the severity ladder, and people go up and down this ladder, right? So, but as you go up the ladder, you would come to our outpatient programs, and then many VAs will have specialty outpatient programs like addiction or PTSD specific treatment programs, or maybe an SMI clinic or women's health clinic that are very specific to mental health. And then at the top of this, we run a number of residential programs across the country. And veterans, actually, the nice thing about being a healthcare system is if I want somebody to go to the best PTSD residential program, I can send them to Florida to that program from Philadelphia without much difficulty. And most of the medical centers also have acute inpatient psych. Next slide. So our number one priority clinically is suicide prevention, and this slide really shows it all. Veterans are at remarkably high risk for suicide compared to the rest of the community. And there's just no way of getting around this. It's been true for a long time. We've done a lot. We've had a lot of efforts to try to reduce suicide, death by suicide amongst veterans. You can see from this graph that we're not making super great inroads despite those efforts. One of the really critical roles that you guys play as community partners in this is that if you look at the rates between the patients that we serve in our hospital systems versus the rates of veterans that don't get care with us, they are much higher rates of death by suicide amongst the community using veterans. That's not a criticism of our community partners. It's just a fact first, but it's also, I think, a reflection of sometimes the disconnected care that veterans get in the community. And we would love to take care more of those veterans and get them into our system. Next slide. So what is our relationship with the community in terms of how do we interface with you guys? we do use the community actually a fair amount. Um, I don't run an eating disorders unit, so in our VA. So if I have somebody that has an eating disorder, I purchase that care in the community. So this is something called community care. Um, and it's good to understand what it is and what it isn't. It really is a program that allows us to take care of veterans when we can't. It's not a program that allows veterans to have choice in where they get their care. So if a veteran wants to get community care and wants us to pay for it, but we offer that service, we're not going to approve that veteran to get community care. This is really, excuse me, this is really for times when we can't provide care. So the criteria are things that we don't do. I gave the example of eating disorders. We would purchase that from somebody in the community. If a veteran lives far away from the service that they're needing, for those that live in the Northeast, this probably is a null set. For most veterans, although it might be since it's drive time, it could be just trying to get across a bridge or something. And if that care, I can't deliver it in 21 days, the veteran then gets a choice to go in the community or get their care and wait for that care in the VA. The other thing here is that this care is not lifelong, it's episodic. So even if I can't see somebody in 21 days for psychotherapy, they'll get authorized for 45 days of psychotherapy in the community. And then if I have it available in 45 days, they have to come back to the VA. So we try to do a lot to educate the veterans about this. It's hard to start treatment somewhere and then have to not be able to keep that treatment going. But these are the rules set out by Congress for us. We don't make these rules up. So and we are also still responsible for that veteran's care, even if we're purchasing that care in the community. So we will ask you for progress notes and treatment plans and things like that. All right, next slide. The Compact Act was signed in the legislation a couple of years ago, and this is an important concept to understand. And this really is the notion of trying to get to that suicide prevention piece for veterans that are not engaged in the VA. It's available to all veterans, and basically what the Compact Act will do is if a veteran is in a suicidal crisis and has suicidal ideation, the VA will pay for care for 30 days of inpatient care or residential care or 90 days of outpatient care anywhere. Doesn't have to be with us. So if they come to an emergency room in the community and they're in suicidal crisis and get admitted to that community hospital, the VA will pay that bill. No questions asked, really. Of course, there's some red tape and some bureaucracy to go through, but it works pretty well. On the slide also are the new crisis line. If you have veterans, remember that when they dial 988, which is the national crisis line, it's after they get connected, they just press 1 and it'll go right straight to the VA's crisis line. So we run our own crisis line separate from the regular 988. And the advantage of that is that those crisis line people can see their chart, they can see their eligibility, they know how to connect them to a local VA. And I'll also say the 988 press 1 is also not just for veterans, it's for family members, but it's also for you. I've used it. So when I've had somebody in crisis that I didn't know how to find or get a hold of, or if we needed to do a police intervention, I'll call these guys because they have direct connections to all the police and so forth, and they're very good. All right, next. Oh, so in terms of the Compact Act, the bottom part of this is the need to call the VA and get that authorization within 72 hours. We cannot go backwards. You do have to call quickly to get paid. Next slide. So I want to say a few things about military cultural competence. I think as we've gone to an all professional military in the US, fewer and fewer people have any appreciation for what it's like to have served. You may have a grandfather that served, but maybe not any other other family members that have served in the military. So it's really important to sort of understand that culture. And I would say that's particularly true, not for surgeons, but for us as mental health providers in terms of understanding the landscape of the family unit and how that veteran's health is impacted by those around them. We know very well, so a real big emphasis here is if you are treating a family or treating a spouse of a veteran, a lot of the stress and a lot of the service-related illnesses that veterans have are translated to their family. Uh, the spouse and the family may have lived on base. They maybe get deployed to Europe when somebody's in Afghanistan. They may, they may live on base housing. All of the stress that the service member goes through. Remember the family members going through a lot of that as well. So we often really think about the family as serving in the service. One question that is just it's simple, but it's important to think about how to ask if you're a veteran. Asking people if they're veteran is probably not very useful. People are veterans of lots of different things. So one thing for you to consider, and like if you have a checklist in your your intake process or something, I would not have a question that says, "Are you a veteran?" Because it doesn't have a lot of meaning for anybody that's outside of the service. So ask very specifically if you have ever served in the U.S. Armed Forces, and then make sure you explore what that is. What did they do? What's their MOS, which is their job category? How did they serve? Where did they serve? Was it a good experience? Was it a bad experience? Were they married or did they have a significant other while they were in the service? And how did the family serve? Those are all important things to explore with a veteran. Next slide. In terms of us and how you can interface with us, I would say get to know us. There are some national resources. So again, the crisis line, and don't be afraid as a provider to use that crisis line. If you have a veteran that is in need of services, they can be a resource to you. There is a website. I'm not terribly good at websites. They tend to be complicated and hard to use, but one of the things that the website can be really important for is the VA, the veteran establishing their eligibility with the VA. Something I did not say earlier is not all veterans, even if they served, are eligible for the health care benefit. Pretty much all veterans are eligible for things like the education benefit and housing loan stuff, but not are all eligible for health care benefits. And that's a very complicated space to navigate. Also set up by Congress, not us. We don't set the rules. Locally, are you near a VA? Or what's your local VA? Who's there? What mental health services are at that VA? Call them up and visit. If you have a bunch of veterans that are in your care and you want to think about where there could be some synergies, go visit the VA. Particularly if you need things like emergency care, specific outpatient care services. Our outpatient programs now are very much organized as a team. So psychiatrists, several therapists, including psychologists, social workers, LPMHCs, etc. They often have peers. There's a robust outpatient services that are available to care for veterans once they come and get seen by us. Next slide. So I think my takeaways for you in terms of learning about the VA is that we probably have the most comprehensive mental health program of any healthcare system in the US. We really do soup to nuts mental health care and psychosocial services, so that broad array, the homeless services, the vocational rehab as well. Get to know us. particularly if you serve a number of veterans in your practice. Figure out the chief of psychiatry. I'm always here. My email is going to be at the end of this. If you're in a location and don't know who it is, it's actually really easy for me to find out. So I'm happy to help with that. Um, Figure out how to be militarily, culturally competent to your veterans. That will go a long ways to making that veteran comfortable with the care that you're giving. And I can't understate the issue of the family serving. It's really important. Next slide. This is my contact, and I'll turn it back over to my colleagues.
Great. Thank you so much, Dr. Oslin. Thank you for sharing your expertise and experience with our viewers. And as Dr. Oslin noted, here's his email address as well as the BHI Collaboratives should you have any additional questions after reviewing the webinar. For a full listing of the BHI Collaborative's previous recordings, please follow this QR code on the top corner of your screen to our YouTube playlist. Please also check out the Collaborative's BHI Compendium for a helpful framework on how you can make behavioral health integration effective in your practice, along with other actionable resources and practice case studies. You can also access the AMA strategic practice guides on the AMA website for implementing specific topics associated with effective behavioral health integration, including pharmacological treatment, substance use disorder, suicide prevention, workflow design, billing and coding, and integrated behavioral health care for older adults. And finally, you can register for upcoming BHI Collaborative and other AMA webinars from the AMA Steps Forward Innovation Academy by scanning the QR code on this slide. Thank you so much for joining us today.